Good afternoon and welcome back. This live Q&A is our third Q&A of today and continues on from our previous session of updates on diagnostics and treatments. Helen and I are delighted to be joined by Maria, John and Juan. And over the course of the next 20 minutes, they will be responding to the questions that you've all submitted over the course of the last three presentations. So to start this session, I'm going to hand over to Helen, who is going to kick us off with her first question to Maria.
Thank you, Gary. Maria, thank you for a really good overview of where we are with radiotherapy. Really great interest to me, certainly. Picking up from your presentation is that as yet, of course, radiotherapy is not yet a proven treatment for cholangiocarcinoma, so that's what we're working towards. But just a very general question, because now things are moving so quickly with all sorts of treatments, and we've got proton beam therapy coming into the equation. And I know now we've got the equipment at the Christie in Manchester and at UCL in London. So do you see proton beam therapy being used in the future for cholangiocarcinoma?
Oh, hi, Helen. Thank you. And thank you for a very timely question. For the audience, we are lucky that NHS England has purchased 2 NHS proton facilities, and at the moment, children are the main focus of treatment. However, there is availability, space, and funding to do research in adults. And cancers of the liver are one of the priorities for proton treatments. And specifically for cholangiocarcinoma, we've put forward that part of the transplant program, the radiation that's given pre-transplant to be delivered with protons. And the idea is that we try and spare as much normal tissue as possible. The other aspect is that any trial that includes radiation can include proton treatments, as NHS England has made available for free protons in patients treated in clinical trials. Thank you.
Well, that's really great news. I'm delighted to hear that. And I've got a sort of a supplementary one for you, if I may, before we go on to others. But you talked about the ABC07 trial, which I know you've been working so hard on over a couple of years now. But how can we encourage specialists to be aware of these trials, especially one like ABC07, to give their patients the opportunity of getting onto a trial like this before they actually embark on other treatments and so then miss that opportunity? Have you any thoughts on how we can encourage specialists to be better informed?
I think it's really a challenging area, and together we are working on multiple avenues. So firstly, the social media and the web page support you're providing. We're really fortunate that only last week I found out that CIUK and Stand Up to Cancer is supporting our trial, and we can promote it that way. And lastly, thinking at the sessions we had before, the multidisciplinary team and the opportunity for patients to be seen in tertiary centers would encourage patients' recruitment. The only challenge that's quite difficult to overcome is that patients will have to travel to receive the radiotherapy, which can be given only in a small number of centers, and that's because it's so specialized. Thank you.
Yes, well, thank you. And what fantastic news about the Stand Up to Cancer campaign. Well done. That just shows that the interest in this disease really is growing now. And let's hope awareness is vastly increased by being part of that. So, Gary, do we have any other questions?
Yes, of course. So I'd like just to turn to a question that came through to one from his session. And the question is molecular profiling and access to targeted therapies available to all cholangiocarcinoma patients, or is it dependent on where you live or access to private medical care? And I think that's particularly focused on the UK, that question.
Thank you, Gary. Thank you, Helen, for chairing this session and the invitation to be on this panel. So we're in a transition period at the moment. Usually there is research-driven biopsies, clinical trials, which allow us to test whether treatments work, and not all of them do, but it's great to have some new ones that are coming along. But we then need to transition across from that clinical trial, the research setting, to then delivering this for everybody. So there's been a lot of work trying to bring cholangiocarcinoma to the attention of NHS England, and we have highlighted with them the importance of molecular profiling, and the future hopefully will mean that patients will be able to have this done through their local genomics laboratory hubs, of which there are 7 or 8 across the UK. So what we're trying to do is to make sure that this comes onto the standard approved test that people can have as part of their normal workup. That's not without its challenges. You've heard from John that different tests will give you different pieces of information, so we need to be absolutely clear that the tests that we're requesting are giving us the answers that we need in order to make decisions. In terms of access to treatments, most of these treatments are initially available through clinical trials, and trials can only be opened in small numbers of centers just because of the logistics, the regulatory aspects of it. But once a treatment has been shown to be effective, it then rolls out into standard of care. And we're just again in a transition period at the moment where pemigatinib is licensed and is under review by NICE at the moment. So that's likely to change in the next few months, we hope.
Thank you. Is there anything you want to add to that, Helen?
Well, I'd like to bring John in on this one a little bit as well, that like Juan, I know, John, that you're very proactive when it comes to getting molecular testing, molecular profiling for your cholangiocarcinoma patients, and very active in putting patients who are eligible forward for their clinical trials. But this isn't so in other centres and with other specialists. What can we do, similar to asking Maria earlier, what can we do to encourage all specialists to think about this and be similarly proactive for their cholangio patients when time is so limited for them?
Thank you, Helen, and that's such a good point. And I guess there are 2 broad answers to this. The first is just to carry on from what Juan was saying about the whole process of getting the population tested. We don't want to sort of do it individually for patients, which we're basically currently now doing. Each patient comes to us, we have to work out what is the easiest way, what is the best way of getting them profiled. And sometimes it's easier than others. But fortunately, through various through trials and through access schemes, we've been able to do it for really the vast majority of people. We don't want to have to do that. We want it just to happen automatically for the whole population. That's going to take some years, but that is certainly the intention of Genomics England, and certainly the intention of the genomic hubs. These are places, there are 7 of them now in the UK, where all these molecular tests will be done, and it is their mission, and I will support them 100%. Well, Juan and I will support them 100% of the way to do that. So that's it. We don't want to have to see a patient. What's the best way of getting this done? It's got to be automatic. Is the easiest way. The second thing to do, the second big hurdle, as I see it currently, is education. Not everybody knows as much about this as Juan and I. Indeed, a lot of people out there arguably don't know a great deal about this, and the education of our colleagues, the juniors that are going to come and replace us in due course. That's and indeed the population that a profile in this cancer is pretty much essential, in my view. It's pretty much essential, and potentially adds hugely to the benefit of any treatment that we can offer you. It's good for the patients, and it's something that we should be aiming to do for everybody.
Absolutely.
So,
Yes.
John, just before we go to a question for Maria, a question's just come in. What steps, if any, are being taken to improve awareness of molecular testing, not only in the patient populations, but also in the medical setting?
Yeah, so how can you teach the doctors? It's sometimes quite difficult. And it's really very similar answer to which I gave just now. If, for instance, pemigatinib, as one said, is approved, then the doctors will have to pay attention to it, because it'll be mandatory to do the test, it'll be mandatory to consider, and your trust is assessed on the extent to which they fulfill these nice guidance. Education in other forms comes with seminars, meetings, continued medical CMEs, continual medical training. It's a long process, but it's one that absolutely must happen.
I think I feel some educational seminars coming on here with you guys and AMMF in the future, because it's novel, isn't it? We haven't been in this position before with cholangiocarcinoma, with something so positive. And really leading on from that, because we're very focusing on molecular profiling and targeted therapies, just to sort of point this firstly towards Juan, but I think really John and Maria will come in as well, that, we are looking at so much at molecular profiling, targeted therapies, but actually for those who really you can't find a targetable mutation, this isn't really any help at the moment. So, and I know Juan has mentioned that the chemotherapy will always have a place in the treatment of cholangiocarcinoma. But the chemos that are currently used have been used for absolutely years, and they're pretty difficult to tolerate for some people, and they're not always effective, and we don't know until they're well on in the course of their chemo whether they're effective or not. So perhaps a very lay question, but will there ever be such a thing as a more refined, gentler chemo that will still be effective? Or does the answer for those people who really don't have the targetable mutations lie in a combination of treatments? What does the future hold? Will it be less chemo, but the addition of SBRT, SERT, proton beam therapy? Could you cast your minds to the future and say what you think?
Thank you, Helen. I think what we need to be mindful of is that when building a house, you have to have a number of different foundations, and surgery will be there as a foundation. Chemotherapy will remain as a foundation, as will radiotherapy, and now molecular profiling. But we're always on the lookout to improve those. So one of the challenges about chemotherapy, if you compare it to bowel cancer, is that we're about 30 years behind. Bowel cancer is very common. All the trials have been done, different agents have been found, and it was previously thought that we just couldn't do trials in cholangiocarcinoma because it wasn't common enough. Now, thankfully, we're in a generation where we are able to do the clinical trials much faster, mostly because of international collaboration. So it is important to identify some new chemotherapy agents, and maybe some chemotherapy agents that are already around but may not have been tested yet. And there are some already undergoing clinical trials. Obviously, with chemotherapy, there are the side effects of chemotherapy. And although the newer chemotherapies tend to be better tolerated in terms of how the treatments have been designed, they will obviously still have some of those side effects to contend with. One of the other foundations at the moment that are being explored is the role of immunotherapy. And we didn't talk about that in this session, but what we do know is that there are some large international clinical trials that have been looking at the role of immunotherapy, using our own immune system to be able to fight off the cancer. And whether that will be effective for everybody or whether it will be effective for only a subpopulation of patients, again, what we need to do is understand from the clinical trials if it does work, why does it work, and who benefits from that treatment. And that may allow patients to have treatment without chemotherapy. So it's very much a development stage at the moment. And what we need to do for an individual patient is, how do we use all of the various foundations available to get the best outcome for that individual patient?
Thank you, Juan. So I think Maria or John, anything, quite a broad question there from Helen that touched many different points. Anything, Maria, that you'd like to add to that?
So quickly, I can add that the other thing we are working on is to understand how the cancer spreads, to better plan treatments. If the cancer is of a local in nature, we could consider local treatments such as radiotherapy or repeat surgery or other local treatments. And that's also another important aspect which perhaps the molecular profiling will help us identify in the future.
Thank you.
And perhaps I could just finish by saying, emphasizing the importance of continuing to hunt. When Juan and I published the original chemotherapy stuff, none of these drugs have been heard of. And none of these targets were well described, and now they're coming onto the license. So, and that's because people were looking at the time. We need to look today for the next generation of targets for us to use. So the importance of continuing to hunt, continuing research in this area is absolutely critical, and we can only do that with the support of everybody out there.
Absolutely. Well, it's really good to know how hard everybody here is working towards this end. So yeah, fascinating. Thank you all for that.
So on to just, John, staying with you, John, onto a question that directly comes from one of the slides in your presentations. I'm sorry to catch you off guard here with this one. For the FGFR inhibitor drugs, the waterfall graphs are very similar, but the y-axis vary. Are there reasons for the different results understood yet?
The y-axis simply reflect the size of the studies, the number of people in the studies there. Actually, that slide's a bit out of date now. It's about 18 months out of date, and the axes have changed several times over. I think it's reasonable to say that they're all, if you did those plots again today with all the numbers of new patients onto those studies, they'd look pretty similar. Slightly less sort of ladder-like, but pretty similar. No, it's just the way in which the plots are done. The message, I think, has stayed the same, and it's a good one.
Thank you, John. One, just go into a question that is a result of your presentation. What are your thoughts about the new KRAS, the G12D inhibitors, and other pan-KRAS inhibitors that are reaching clinical trials this year?
Yeah, thank you, Gary. So KRAS is an oncogene. So if you think about an accelerator and a brake pedal, KRAS is an accelerator pedal that's down to the floor, and it's forcing cells to become cancerous. We know that KRAS mutations tend to vary. So we've been talking quite a lot about intrahepatic cholangiocarcinoma, but in fact, KRAS mutations tend to be more common in cancers outside of the liver and gallbladder, in fact. Now, KRAS has been one of these very difficult targets to actually treat, and there are a different number of mutations that can happen in the KRAS gene. Thankfully, now there are some agents that are beginning to come through for specific mutations of KRAS. And what we need to do is to just gradually study these drugs. We're not in a position where we can just randomly use them if we think it's the right thing. We need to be very methodical about developing them, probably in the most common types of cancers with those mutations. But at some point, no doubt, they will be looked, again, specifically in patients with cholangiocarcinoma who happen to have that specific mutation. So at the moment, exploratory.
Thank you, Juan. We've probably got enough time for one last question. So let's quickly see what we've got here. So I'm going to ask this question broadly, and please feel free to speak up, whoever wants to answer it. Is there anything known regarding the resistance mechanisms of FGFR2 inhibition in cholangiocarcinoma? Any volunteers?
Yeah. That's a great question, and it's a subject of great frantic activity over the last year or so, and suffice it to say that with respect to the resistance, and it's probably the emergence of other mutations within the same gene within that cancer. So these are probably mutations that were in the cancer right at the beginning, but there were hardly any of them, and over the period of the treatment they've grown up. And it's a question of either designing even better drugs to treat those as well, and potentially there are some of those around, or mixing in drugs to treat these things simultaneously. That's what's been done in other cancers. So yeah, that's and so Juan and I both in the throes of designing new studies to do that, and in order to deal with that exact problem. That's a great question. Juan, I don't know if you wanted to add.
Yeah, I was just quickly going to add to that. Understanding what happens relies on us often getting another biopsy. So we're grateful to many patients who agree to undertake a further biopsy, which is not comfortable once they've been on treatment, for us to really understand what has happened, what has changed, why has this now stopped responding to treatment. In future, it may be possible to do some of these as blood tests or the liquid biopsy, but again, just thanks to everybody who agrees to have these biopsies, because that's the only way we're going to untangle the story.
Fantastic, thank you. Well, it's a great shame that we can't continue this conversation and get through the other questions that we've had in. But on behalf of the AMMF, thank you, Maria, John, and Juan, for taking the time not only to perform your presentations pre-event, but also attend the session. So thank you very much. Enjoy the rest of the conference, and thank you to everyone that's been able to join.
Thank you.